So for those of you who've not come across us before, SHAAP, Scottish Health Action on Alcohol Problems, is a partnership of the Medical Royal Colleges and the Faculty of Public Health in Scotland. Our role is to provide an authoritative voice on alcohol harms and on potential ways to address those harms in Scotland. SARN, Scottish Alcohol Research Network, is a network of researchers and academics with an interest in alcohol public health policy in Scotland. The network aims to share knowledge and skills and facilitate discussion and build connections between researchers. So if you fit the category and you're not a member, please do join up. You'll be able to find details on our website or via emails, etc. But the more members we have, the more effective it becomes. The purpose of our series of occasionals each year is to share topical research and give others in the research community and beyond the opportunity to ask questions and discuss ideas. Our theme this year is alcohol and society, which we chose because alcohol is part of the lives of everybody in Scotland. That's whether you consume alcohol or don't, it's simply present on a daily basis in all sorts of different ways. So this theme does bring us a lot of rich and diverse perspectives, which should be relevant in a number of different ways. Today's presenters are Dr. Kat Jackson and Dr. Amy O'Donnell. So Kat is a research associate and early career researcher in the Population Health Sciences Institute at Newcastle University. She's a health services researcher with a background in sociology. Her research focuses on women's alcohol use and mental health, and she develops interventions or research into developing interventions to reduce health inequalities. Kat's interested in ethics in practice and research about sensitive and emotionally demanding topics. She is co-convener of the British Sociological Association Alcohol Study Group. Amy, our other speaker today, is a National Institute for Health and Care Research Advanced Fellow and a lecturer in public health at the Population Health Sciences Institute, again at Newcastle University. Her research aims to improve provision of appropriate care for people with multiple complex needs, with a specific focus on substance use and mental illness. Alongside research that explores the potential for using digital technology to improve care navigation for heavy drinkers with depression, she also co-leads the evaluation of various alcohol recovery and mental health navigators programs. And she's also co-investigator on a research collaboration with Edinburgh University, which is looking at developing new models of care for older adults with complex needs. So today, Kat and Amy are going to be talking about alcohol use and depression, which commonly co-occur. They're drawing on data from a study conducted in the northeast of England, which is a region with some of the highest levels of alcohol-related harm in the UK, and has many parallels to Scotland as well. So I'm sure this research will stimulate a lot of questions, so do please remember to post any questions or thoughts in the chat box, and we'll turn to these as much as possible after the presentation. So without further ado, I'll now turn to Amy, who's going to kick off with today's presentation.
Thank you. I think Kat's going to share the slides. So good afternoon, and thank you for the opportunity to join everyone today. It's so great, if slightly intimidating, to see such a fantastic turnout. And we're really grateful for this opportunity to share the findings from the first phase of the ADEPT study, which is looking at care provision for people with co-occurring heavy drinking and depression. Next slide, please. Before we start, some acknowledgements. First, just to highlight that the study is part of a wider programme of work that's funded by the NIHR through an advanced fellowship. In terms of conflicts of interest, we have no conflicts to declare in relation to this work. I've previously co-authored papers looking at impact of various industry-focused measures that have used household purchase data under a contract with Candar World Panel, and the cost of that was indirectly reimbursed by AB InBev. Next slide, please, Kat. I'm not sure the slide has changed.
I know, I'm just trying to, let me just go back. I'll just stop sharing for a minute and then I'll...
Okay.
There we go.
There we go.
About that.
Great. Okay, so yes, today myself and my colleague Kat are going to talk about some of the challenges involved in treating people with co-occurring heavy drinking and depression. And we're going to draw on some qualitative data from the ongoing ADEPT project. I'm going to start and I'll give a bit of a background and some wider context to the study. Then I'll hand over to Kat, who will talk about the methods we're using, and she'll present some findings from the interviews that we've conducted with a range of service users across the North East and North Cumbria region. And in doing that, Kat's going to use some illustrative narratives from service users that we've put together to try and show the types of experiences people can have when attempting to access care. And then she'll move on to outline some of the overarching themes that we've identified in the data. We'll then finish with our initial thoughts on the meaning from this phase of the study and some ideas about what the implications might be for policy and practice. Next slide, please, Kat. It isn't liking you moving the slides, is it? Oh, you're on mute. I wonder if we should see if this happens again, and if it does, whether somebody at SHAAP could maybe take over the slides. That would be great.
It's to do with the way I'm setting up my view. I'll stop fiddling now.
Right.
Sorry.
Okay. Okay. So just to give some kind of background and context to the wider study, a range of data show that there are high rates of mental ill health amongst heavy drinkers. Conservative estimates suggest that a third of those who drink heavily will also have experienced depression at some point in their lives. But we know that rates are much higher the heavier people drink. So, for example, amongst people with alcohol dependence, around 80% are likely to also have mental ill health. The relationship between harmful alcohol use and depression is complex and bidirectional. People with depression are more likely to drink harmfully, but at the same time, harmful levels of alcohol can act as a depressant in themselves, leading people who are drinking excessively to experience depression. We also know that for those individuals, health and social outcomes are worse, and they're worse compared to people who are experiencing either of those conditions in isolation. And these risks include much higher risks of self-harm and suicide. There are, in theory, effective treatments for both heavy drinking and depression, at least when treated in isolation. But in reality, we know that many service users struggle to get the right support. In part, this is because of all the usual implementation issues that can adversely affect delivery of treatments and interventions for substance use and mental health. But when people are facing these issues concurrently, delivery of care can be even more messy and fragmented. Multiple providers are going to be involved in provision of care, including providers from primary, secondary and tertiary care sectors, as well as both statutory and third sector organisations. Services are commissioned by different bodies, clinical commissioning groups, for example, versus local authorities. We also know that current practice and associated guidelines in general are primarily designed to identify and treat single diagnoses, single conditions. So with few exceptions, you'll find that sort of mental health guidelines don't always contain a reference to alcohol-related issues, and likewise those that are related to harmful drinking rarely address mental health. And the upshot of this is that you find service users facing substantial challenges in navigating this fragmented care system. And they're doing this often at times of crisis when their own motivation and resilience are likely to be substantially impaired. And what we know from other evidence, and perhaps most frustratingly, is the fact that because of this focus on single diagnoses, narrow and or conflicting eligibility criteria can mean that some individuals are effectively blocked from accessing appropriate care. So if somebody's drinking heavily, they might be ineligible for mental health support, and those with relatively severe mental ill health can struggle to get help for their drinking. Next slide, please.
Maybe it isn't me then.
Are we able to switch over?
Yeah, we'll do that now.
Yeah, sorry.
So I think it's slide 6.
If you would like to carry on, Amy, while Hannah gets the presentation up, that would be great.
Okay, will do. So the next slide was really presenting some sort of key figures, really, to show that, as in parts of Scotland, those living in the focus region for the study, the North East and North Cumbria, show a particularly high levels of unmet need in relation to both substance use and mental health. There's lots of data that shows people in the northeast of England, they drink more, they experience more alcohol-related harm, and they have worse mental health than in most other parts of England. And there's lots of evidence to show that this situation has worsened during the pandemic in both of these areas. So, for example, we know that the Northeast experienced a larger drop in mental well-being, more loneliness and higher rates of antidepressant prescriptions during COVID compared to other parts of the UK. And we also know that alcohol-related deaths peaked during this period in the Northeast, and that people who were drinking heavily were the most likely to have increased their consumption during the pandemic. Next slide, please. However, are we still having trouble moving from? There we go. Those facts and figures that are focused on mental health and substance use are only kind of part of the story. And there's lots of evidence to show that the northeast of England as a whole experiences relatively high levels of deprivation compared to other regions. For example, it's got the second highest rate of child poverty in the UK, and it's experienced the biggest increase in child poverty levels in the last few years. We also know that there's a persistent north-south divide in both life expectancy and healthy life expectancy. People in the south of England live longer and live with more years of good health compared to those living in the north. But even within our region, different communities and localities experience different levels of harm, need, and variation in service provision. And I've given some snapshots there to show the Northeast and North Cumbria as a whole. I mean, it covers 3.2 million people, and they live in a particularly diverse range of geographies. This includes areas like the Newcastle Gateshead quayside that's benefited from quite a lot of investment in recent years, to post-industrial urban wastelands, particularly in the south part of our region, as well as stretches of fairly isolated rural wilderness in parts of Northumberland and in Cumbria. And all of these will include pockets of relatively high levels of socioeconomic deprivation. And all of these contextual and wider system factors really need to be taken into account when we're thinking about the health and care needs of heavy drinkers with depression. Next slide, please. There are some opportunities today in theory at least, to sort of provide more joined up care for people with these kinds of multiple complex needs. Most obviously, the move to integrated care systems potentially signals a move in the right direction. For those of you that aren't aware of these, in England, these bring together all the organisations that are responsible for planning, buying and providing healthcare, including substance use and mental health, across a specific population. There are also opportunities to draw on developments in new models of care delivery, including digital technology. At the same time, we know that care providers can still struggle to work across boundaries, organisational, geographic, and that there are concerns about individuals' capacity to access and benefit from care when delivered online or otherwise. And this is the space in which the overall ADEPT study is situated. And our overall aims are to firstly explore how support for patients, service users with heavy drinking and depression is currently delivered across our health and social care system. And we're using the North East and North Cumbria really as a kind of case study example. And in the next phase, we're going to use co-production methods to develop a resource to try and help those patients better navigate and access the right care at the right time, likely to be linked into primary care and likely to draw on digital technology where appropriate. And I'd now like to hand over to Kat.
Thanks, Amy. Next slide, please. So, as Amy just mentioned, the study involves 3 interlinked work packages. In the first stage, we've interviewed people that use and provide services for heavy drinking and mental health to find out what they think about current care, including their views on using digital technology. And that's what we're going to be presenting on today. At the moment, we're working with patients, service users and care providers to co-develop a digital resource to help address some of the issues we've identified through the qualitative work. And finally, in the last bit of the study, we hope to pilot this digital resource, probably in primary healthcare, to find out if it could be effective and hopefully use the findings to inform a future full-scale evaluation. So the study began in August 2020 and it's running till September 2024. Throughout it all, we're working closely with people with lived experiences of these issues and with service providers to help ensure our work reflects real need. Next slide, please. So in the next section, I'm going to focus on our findings from the interviews that we've done with people who access services for heavy drinking and depression. But those people included people who were drinking above harmful and hazardous levels, but most people were drinking a lot more than this, and many were drinking at a level that would be considered alcohol dependence. As well as mild to moderate depression, many people also had other mental illness and also experienced a range of other social issues. The interviews were carried out between June last year and April this year. And this period was when there were still a lot of COVID restrictions in place. So many had experienced changes in service use during this period. And while that COVID wasn't necessarily the focus of the study, it was obviously the backdrop to the interviews. People were recruited via community and voluntary organisations, their GP surgeries, alcohol services, stowable sampling, a range of ways. We drew on a methodology called interpretive description. We used semi-structured interviews, which were done face-to-face or by phone or over Zoom. In the interviews, we explored both the positive and negative experiences of accessing support and both physical and digital services. The study had ethical approval from an NHS ethics committee. Next slide, please. So this slide just shows the breakdown of our final sample of participants. We spoke to 39 people overall, a fair balance of male and females. Most of our participants were between 30 and 59, but there were one between 20 and 29 and 4 were over 60 years. The majority of participants were white British, and we recognise this as a limitation of our study and hope to build on this in future work. representing kind of the population that were often accessing services. Most of the people that we interviewed were from the most deprived areas of the region. And then the next parts just show the relationship status of participants and their employment status. Next slide, please. Okay, so in this section, I'm going to present the common themes that we've identified through our analysis of the accounts of the 39 people who took part in an interview. However, because the people's experiences were very complicated and different, and they had both good and bad experiences, what I want to do first is show you the experiences of 3 exemplar people that we spoke to that have been drawn into comics by an illustrator that we've been working with. These aren't real participants, but they bring together various people's experiences that we spoke to, and it's really just to give you a flavour of the kind of experiences that people we spoke to had. And they've anything that has kind of based on any of the participants has been anonymised. At this point, I also want to give a content warning. So some of the issues that we're discussing could be potentially upsetting or distressing. And I hope you can see the detail in the screen on the comics. So the first one, next slide, please. I'll just give you a little bit of time to just have a look at that. So this person is Christina. Christina lived with her teenage daughter and she was currently on sick leave. She said she didn't like it when people suggested her depression is because of her alcohol use, because she felt that her depression, her alcohol use was closely related to her depression. She feels that she uses alcohol to mask feelings associated with depression, and it got heavier over time. She had had medication for depression since her late teens, but had never really disclosed her drinking or been asked about her drinking by her GP. But more recently, she'd been referred to IAPT, which is talking therapies. And after a couple of sessions, she disclosed to her therapist, who she'd built up a good relationship with, about her drinking. At this point, her therapist had told her in a nice way that she had to get help for drinking before she could continue with support from them. So she went on to seek help for her drinking from the local alcohol service, self-referred into them. She really valued the peer support that she got from the alcohol service, and she felt overall that they do address mental health to some degree, but she also said that they were not experts. She feels she still needs professional help, but hasn't actually accessed any other professional help other than IAPT yet. She has support from a social worker who is also in contact with her GP, and she has some support for other social issues, but she feels that any joined up working that takes place isn't focused on her, it's focused on her daughter. Next slide, please. So the next person I want to introduce you to is Luke. Just let you have a look at that. So Luke associates his depression with a series of bereavements and other difficult personal circumstances, and like Christina, had received medication for depression for quite a long time. He has always drunk heavily socially, but began to use alcohol to manage feelings associated with depression after his mother died. Following a drink driving incident, he was made to seek help for his drinking. He'd never sought any help for his drinking previously. And he had a worker with lived experience of heavy drinking, and really valued talking to them, and they helped him to reduce his drinking. However, around this time, he also lost his job because of the drink driving incident, and his home and his marriage broke down. So although he'd reduced his drinking, these difficult circumstances made it really difficult to continue stopping drinking. And when the pandemic came along and the lockdowns, his drinking gradually increased again, partly because he didn't have anything else to do. He has help from a housing organisation who he feels give him a level of help with his mental health, but has never actually had any formal help for his depression other than medication. In fact, he queried whether talking about his problems would help him. He is worried about accessing support for alcohol and mental health because he's worried it could affect his custody of his children and his future work opportunities. Next slide, please. The person I want to talk about is Bella, and I'll just let you have a quick look at that. So Bella is in her early 30s and she lives alone with her cats. She had previously had an active social life, which involved alcohol, but had to give up work after a physical illness and now can't afford the things she used to do. She's too young to claim a pension, so she relies on universal credit. Bella sought help for her alcohol use from her doctor following an incident where the police were called to a family argument. At this appointment, the GP didn't actually offer any direct advice about alcohol. She said she wished they had offered her help. She also said that she told nurses and GPs about how much she drank in the past. She was drinking about 80 units a week. She said they didn't seem bothered and they didn't offer her any advice, and she wondered if everyone else was drinking the same way. She has medication for depression, which also seemed to be related to loneliness and sense of isolation. She didn't see many people in the week, apart from her main company was her cats. She wasn't sure if her alcohol and depression were related. She said she was trying to drink less, but didn't have much else to do. She had tried alcohol-free drinks, but these were expensive. She doesn't talk to anyone about her alcohol or depression because she doesn't want to bother them. So these three people give a sense of the variety of the experience of the people that we've spoken to. I'm now going to move on to present the three main themes that we've identified in people's accounts of accessing services for alcohol use and depression. Next slide, please. Okay, so almost all the participants that we spoke to conveyed that they experienced their depression and heavy drinking as related. The biodirectionality that Amy mentioned at the beginning was really evident in people's accounts. But most commonly, people suggested that they felt their alcohol use partly stemmed from their depression, and they were using or had used alcohol to escape or help dampen feelings associated with depression. Some also mentioned that they felt their drinking made their mental health worse, both depression and anxiety. For this first theme, lack of recognition highlights both people's sense that services aren't connected and that the relationship that they perceive between their alcohol use and depression is not recognised by services. Next slide, please. So almost all the participants said they felt services for alcohol use and depression were separate and that services generally didn't work together. While people felt their depression and alcohol use were related, this was not recognised by the system. And I think this is illustrated by the quote from participant 9. It's really common across people's accounts. He said, "They're not the same service, that's the thing. The community mental health team are different to the alcohol, whatever you call it, team. If you said anything about your drinking to the community mental health team, they would say, that's not my area of expertise. You need to talk to people at the alcohol service for that sort of thing." So as well as services being experienced as separate, many people's accounts also suggested the relationships between alcohol use and depression weren't recognised in their individual interactions with practitioners. People did not seem to be being routinely asked about alcohol when they were consulting for drinking, depression, or being asked about depression when they saw their GP about alcohol use. Unsurprisingly to many people here, many people's accounts highlighted the shame, stigma, embarrassment that they could feel about their heavy drinking, and this could prevent them from wanting to disclose their drinking to professionals. But at the same time, some people's accounts suggested if they'd been asked about their drinking, they might have opened up. And this is illustrated by participant 16, who was in touch with the community psychiatric team, community psychiatric nurse. And he said, "I didn't always feel listened to when I was going to see the CPN. community psychiatric nurse. I mean, if I haven't emphasised my alcohol use, well, I have made them aware, but I haven't emphasised it. Maybe it's because there's a lot of shame involved. I don't know. I just feel like if help had been offered, I probably would have gone for it. But with a lot of things, I'm just getting the impression that I have to sort myself out. So this participant 16's account highlights one of the kind of themes that were running through the other themes, which was this really strong sense of personal responsibility that people were made to feel. He felt a real sense that he was expected to manage his drinking himself. And as I said, this came up frequently in people's accounts, and you'll probably be able to see it through some of the other quotes that I'm going to be presenting. Next slide, please. So some people conveyed that professionals could dismiss their sense of a connection between their alcohol use and depression. For example, participant 35, who felt her drinking and depression were related, said, "My GP, one of them, she went, 'You haven't got problems with your mental health. You're not depressed. You've just got a drink problem.' She went, 'Stop drinking and everything will be all right.' So 10 months down the line, I went back to the doctor and said, 'I've stopped drinking, like you said, and I don't feel any better. And when I do, because I'm in a better place, but there's definitely days where I know I'm not a well person.' So even though she'd sought support for alcohol, as she'd been told to, she still didn't feel like the underlying depression had been treated. So participant 19's comments were quite typical. He explained that he felt that if his drinking had been addressed before or alongside, if his depression had been addressed before or alongside his drinking, he may have reduced his drinking sooner. And there were quite a lot of people that just felt they'd been going around in this circle and never getting the support they needed to. So he said, "I hit the drink because of my mental health and my depression. So if that had been cured, sorted first, the mental health side of it, I don't think I'd have been drinking or drinking like I am, because your drinking is there because of your depression and everything else." So overall, the configuration of services had real implications for participants who had to navigate separate systems that didn't usually tend to work together. And also the lack of attentiveness to what was important to people, the relationship between their alcohol use and mental health, or the social context of their alcohol use more broadly, was extremely frustrating. Next slide, please. So moving on to the second theme that we've identified then, nowhere to go. As well as services for alcohol use and depression being mostly experienced as separate, participants' accounts suggested that GPs could often lack information about alcohol services or lack eligibility criteria for mental health services. Mental health professionals often couldn't offer them any help at all or lacked relevant skills and knowledge to support them to reduce their drinking. And alcohol services could try to support around mental health, but often didn't have professional expertise around that. And people could often be turned away from mental health services if they were drinking, leaving them with no options for support. So what we saw throughout the people's accounts was a lot of gaps in care and periods where people had no support at all. The next slide, please. So some people in the sample had been in touch with their GP for depression, but explained that when they had disclosed heavy drinking, they were no longer able to get this medication or any support for their mental health from their GP. So participant 23 had been on medication for depression for a long time and explained that she had sought help for her drinking herself, following encouragement from her daughter. She said that when she told her GP she was seeking help for alcohol use, they said she could no longer access support for depression. As some other participants did, she conveyed that her GP not helping her to manage her mental health had led to her being pushed out. And again, that sense of personal responsibility came through really strongly. She wasn't signposted to any services as she'd already accessed them herself with encouragement from her daughter, but some participants were told to try to reduce their drinking themselves before they could seek support. And that point of self-referral could often be really challenging. A lot of people that we spoke to could see where they stopped getting support when they were asked to self-refer to services as well. So participant 23 said, I've been on antidepressants for years, and I had asked if there was something they could do to change my tablets or raise my tablets to help my mood. And he just said, no, not until you've addressed your drinking. Once you've addressed your drinking, we'll address your mental health. So that's really similar to some of the quotes on the last page. The example from participant 10 illustrates that doctors could often lack information about inclusion criteria and the common theme that people can be turned away from mental health services if they were drinking. So she said, my doctor suggested talking therapies. They said they deal with CBT and they do PTSD and things like that. So if he referred me over to them, and then they did a telephone assessment. And during that time, obviously I was honest. They said, are you drinking? And I said, yes. So she was like, oh, I can't help you. You can't get help from talking therapies whilst you're under the influence of alcohol. And again, this was quite a common experience. And I think it was mentioned at the presentation that Amy and Annie did in the last SARN SHAAP presentation around self-harm and alcohol as well. Some participants that we spoke to spoke about lying about their drinking to get help from mental health services. Next slide, please. Okay, so this quote from participant 3 also illustrates that people are often turned away from mental health services if they're in touch with alcohol services or if they were found to be drinking heavily. I've got this quote because the sense of frustration and desperation came through really strongly in his account. He'd been told by his GP that he had to access help for his drinking before he could get help for depression. He'd been with the alcohol service for a year, and then he went back to his GP, who'd referred him to the psychiatric nurse, and then he had this interaction with the psychiatric nurse, even though he'd reduced his drinking a lot. He said the community psychiatric nurse called up, and it was one of the most horrible conversations I've had in my life. She just didn't want to know. She said, if you're with the alcohol recovery services, there's nothing we can do. I was absolutely distraught. So we get there the sense of nowhere to go. This was also illustrated by participant 2, who'd been turned away at a point of crisis, and it resulted in plans to end his own life. He explained that he was particularly frustrated because he'd already tried to reduce his alcohol use, and that hadn't helped him really. So he said, I went to the hospital and said to them, I'm having intrusive suicidal thoughts. I don't know why I'm frightened. And their response was, unless you reduce your alcohol to 13 units a week, you will receive no treatment from the NHS or from private practice. And I came out of the hospital and thought, well, that's it then. That's it. Nothing is going to change. I'm not going to get any help. 3 weeks later, I had planned and organised my own suicide. Fortunately, he did go on to get really good support from his GP, but there certainly were participants that we spoke to who had friends and acquaintances who they attributed suicides by those people due to this situation. So participant 28, often people were being bounced around the services for a really long time. So participant 28, again, shows how difficult it was to navigate the system and that people felt pushed out. He explained, you just tend to get bounced around different services and nobody grabs hold of the issue and decides to tackle it. Moving it on somewhere else seems to be the only thing, if you see what I mean. And it's not easy when you are depressed to go and look for help. So overall, not being able to access any support had really tangible effects, real effects. 1 or 2 participants, as I mentioned, spoke about friends who died by suicide when they couldn't access support. It was also evident that feeling of no one wanting to take responsibility for them or care for them led to people feeling they lacked value, which could also contribute to distress when they were already distressed. Okay, next slide, please. Okay, so this final theme, inequalities in care and support, highlights that although services seem to be fragmented and were fragmented, and I've presented some of the more negative aspects of people's experiences. Some people experience greater inequalities in accessing care and support than others. And as I mentioned, even though the data I've presented so far presents a bleak picture, some people had been able to access good care. And I'm just going to talk a little bit about that now. So next slide, please. So while people's accounts suggested that it could be difficult to access statutory mental health care if they were drinking, there were examples which suggested that they had been able to access support for mental health in other services. So for participants who'd accessed community alcohol services or AA or SMART meetings, many emphasised that alcohol services inevitably had to address mental health because it was so prevalent in the people who attended them and so bound up in people's reasons for drinking. So participant 14 mentioned, I think they're not mental health specialists and they're dealing with things that they're not trained in. Actually, in my experience, they're really good, even with the mental health stuff, but it's not their job. Do you know what I mean? So many people also mentioned the good care that they'd got from community and voluntary services or other local authority funded projects. These organisations appear to provide a more preventative type of support that they seem to need. These organisations had sometimes been able to provide support for their mental health and general well-being, even if they were drinking, or they'd been able to support them while they waited to access statutory mental health services. So they were plugging the gaps. Practitioners in these organisations often offered a listening ear, someone who checked in with them, helped and encouraged them to access other services, and could sometimes tailor services to their individual needs. So participant 28 is the same participant whose quote was the last one I read out in the last theme, who'd been bounced around services for a long time, and he'd recently come into contact with a community organisation who was giving him a lot of help. And he said, I'm in the community organisation, people have been good. I wish I was put in touch with them earlier because they are any problems. It's not, oh, we just deal with so-and-so, we just deal with that. You will have to go and see somebody else. It's sitting down and actually tackling, getting to the feeling as if the problem is being tackled and not just a little speciality. Next slide, please. However, even though there was this support in place for some people and available to some people, because we were interviewing people across a wide geographical area, it was really noticeable the difference in these type of services that were available for people in different areas of the region. And it was also notable that the way people found out about these organisations could sometimes seem accidental. So participant 5 was in recovery when I interviewed him, and he had most of his support withdrawn, but he still felt that he needed some help. And he spoke about how he'd found out about a community organisation and the support they were giving him to just have the opportunity to just talk about things. So he said, I didn't even know this place existed until a couple of months ago. I thought it was joined onto the hostel across the road and they were the only people that could access this. I didn't know you could come for problems, I'll just talk. Yeah, so that real inconsistency in how people found out about things and the inconsistency in these community and voluntary organisations that are available across the region was really obvious. A small number of people that we spoke to spoke about accessing private sessions, but this was a really small number. And most of the people that we spoke to just didn't have the resources for this. Another kind of area of inequalities was that we noticed that what a difference having friends and family that could advocate for people could really make. So most people that we interviewed tended not to have a strong sort of social network of people to support and advocate for them, but for those that did, it really shone through. So for participant 25, she explained, if you shut yourself off and don't answer your phone and don't engage, it makes the services cut you off. I think they just discharge you. And it was only really my family and friends that were having to ring on my behalf and say, she's not ignoring you because she doesn't care. She's ignoring you because she's not answering the phone. So she went on to get support, but you can imagine if she didn't have that lot of people behind her supporting her, it might have been a really different experience. And I've just got the final quote I've got there is from participant 27, whose was full of she was just extremely lonely and isolated. She explained, normally every day I'm by myself and I don't talk about anything. I've got an auntie who sometimes pops in, she doesn't know what's wrong with me, but sorry, she does know what's wrong with me, but they don't mention anything. It's not someone I can talk to about my situation. So I guess in that we see, again, going back to what I was saying earlier about the stigma and shame and embarrassment that can be around heavy drinking could sometimes stop people asking family or friends for support. So that's really the end of this part. I just wanted to mention that like most people in the sample were really, because of the lack of social networks, were really reliant on the professional support they had, which was hugely variable, and they were often managing alone for long periods. Community and voluntary sector offered really valuable support, but this was not consistent or guaranteed. That's me. Into Amy.
Amy, you're muted.
Sorry. Thank you. Next slide, please. So across those stories, I think the findings really highlight the lack of joined up preventive care that's available for people with co-occurring heavy alcohol use and depression, as well as some of the practical challenges people experience trying to navigate this health and social care system. We're focused here on one geographic region of the UK, but I think that the messages undoubtedly translate to other parts of the country. Some of the issues that we've highlighted here today are to do with the design of the care system itself, where this continued focus on treating single conditions or issues in single services is really at odds with the far more complex needs of these kinds of patients who have got multiple needs and issues. Some of these sort of messages are to do with the fact that the system itself is really inadequately resourced, particularly where substance use and mental health services are concerned. We know that care professionals are struggling to cope with the volume of need in both these areas, and that in some circumstances can lack the relevant skills and experience that would enable them to provide appropriate care. And certainly many of the service users themselves were highly aware of these limitations in the system. Some of these structural barriers are also to do with the characteristics and living situation experienced by service users themselves, who are experiencing a range of obstacles to engaging in and benefiting from support, whether that's face-to-face or digital. Next slide, please. And that point really links to the other main message from this study, that the individuals who are trying to access care in this messy, frustrating system are themselves highly vulnerable and often socially and economically isolated. Yet, despite these vulnerabilities, because the system at present is working to push service users out rather than pulling them in, they're forced to be obliged to take responsibility for their own care and recovery, which then don't necessarily have capacity to do, and of course in itself can contribute to their sense of distress and isolation. Many, if not most, of the people that we spoke to live in relative high levels of deprivation. And we know from lots of other studies that that makes kind of service access a lot more challenging. As Kat told us, some, probably a minority, have friends and family to support them or to advocate for and help organise their care, but most didn't. And others felt unable to ask for help because of the deep-rooted stigma and shame that they experience around their conditions. Next slide, please. I think some of the implications for policy and practice are pretty clear, and many of these kind of findings echo messages from other research in this space. They also echo many of the recommendations from the recent Carol Black report. I think the first point is we really need some meaningful implementation of joined up care. And some of that is to do with the kind of the design and commissioning of the kind of health and care system. We need that to be underpinned by appropriate contractual arrangements and commissioning arrangements. so people can access comprehensive support wherever they enter the system. Some of this will mean the need to upskill care professionals so they're better equipped to deal with the kinds of complex issues that people with coexisting mental health and substance use problems are facing. In England, at least, integrated care systems could maybe have potential to play a role in facilitating these improvements, although clearly more investment is needed in these services. However, even if all these kind of structural improvements take place, it's really important to ensure that the support actually reflects the needs and preferences of service users themselves, because at present it clearly isn't. I think a real strong message coming from our research is that they want sort of validation from care professionals. They want them to recognise in a formal and meaningful way their own understanding of the link between their drinking and their mental health. They want care that's more sort of meaningfully adapted to their own abilities, capacities and available resources, which, you know, varies from individual to individual. And that isn't just about sort of material support, and it's not even just about health literacy. A real strong message that came through from our interviews was, when it comes to mental health and substance use, social support and being able to access peer networks of support is a real critical part of that package. And the system, the formal system, needs to do more to formally recognise and facilitate those kinds of links, particularly in the more kind of isolated service users that we spoke to. Next slide, please. So as we mentioned, these interviews are the first in a series of phases in this research study. We've also interviewed service providers alongside these interviews about their experiences, and we'll share those findings soon, and we'll be happy to answer any questions about those after we finish. At the moment, we're holding several workshops with service users and providers to try and develop and refine a digital resource. At the moment, this is looking like it could be a kind of a suite of tools and functions that might include things like links to wellbeing apps and directories of physical and digital support services, that it would help people find sources of social and peer support, but that it also might have some other kind of statutory system-based components that would help do things like facilitate more joined-up care, such as helping share patient data with consent across services. And then in the final phase, we're going to pilot the resource, probably in primary care, but that dependent on the outcome of the workshops. And this whole process is supported by close conversations with people with lived experience and our technology provider, which is NHS Health Core. Next slide, please. So before I finish, I just wanted to thank a range of people that have made this research possible. I think the first thing is to thank the 39 individuals that took part in these interviews and shared deeply personal and often traumatic experience with us. We very much appreciate their time. We'd also like to thank Dave, Des, Carol, Fiona and Hayley, who make up our amazing Study Lived Experience advisory group, who are an invaluable part of the team. And also thanks to Maria, who is the illustrator that we've worked with to produce these amazing visual representations of our research. And I hope you agree that they really kind of bring what is a very complicated story to life. And finally, thanks to everybody here today. And we'd be really keen to hear your thoughts, comments, and answer any questions. Thank you.
Well, thank you so much, Amy and Kat. That was such an illuminating presentation, in part because of the content and the research that you've carried out, and also to have such clear recommendations about what can happen in policy and practice as well, which was great. But also the way you presented it, and the fact that we had the graphic representation of the research findings, which has in itself generated some questions. So there've been a couple of questions or observations, people wanting to know, can they use these graphics themselves with their students and with other audiences. But fundamentally, I think questions around, if we can just look at this side of things first, could you just explain why you went down the route of presenting your findings in this way, and what works about it, and what the advantages of taking it forward in this way?
Okay, I'll start, and then maybe Kat could kind of chip in. Well, I mean, I'd love to say that we're the first people to ever do this, but we're not. And we've seen some colleagues who have worked with these kinds of populations do this sort of, visual representations of research, and thought it was so effective. They've done slightly different approaches, but what we really wanted to do was to bring the themes to life, because a lot of the time, the theme names can be quite broad things, but there's a whole kind of layers within that, and a picture can show that so much more easily, and is much more kind of accessible than reading a full kind of academic paper. We also felt that really what brings it to life was the individual stories. That really showed, more than these overarching themes, the lived reality of what it's like trying to kind of battle a really frustrating system. And it was Kat's idea to use the kind of the comic strip idea to try and illustrate that. Don't know if you want to say something, Kat.
We had a conversation with our study lived advisory group as well, didn't we, about some of the ideas that we were having for dissemination. And we were suggesting kind of various options, and one of them mentioned they'd seen a comic from the 1980s that they had somewhere in their house that they loved and they'd remembered, and I think that was part of the decision as well, to do it that way.
Oh, that's great. And is it going to be possible for some of the participants who would like to use these graphics in the future, is it going to be possible for you to share them for use elsewhere? Would that be possible?
I think we will do that. I mean, it's publicly funded research, so I think that's kind of part of ethically what we're here to do. I'd say if the illustrator in particular could be acknowledged, that would be great. The thematic illustrations are pretty final. The comic strips, they're roughs at the moment. There's a few little tweaks that we want to make to some elements, but they should be done within the next few weeks. So I think people are welcome to get in touch with us if they wanted to access those. Like I say, definitely acknowledge Maria. Also, if you can acknowledge the research, that would be great. But I think the findings translate to telling lots of different stories, and the idea was that it's going to kind of help people explain what is quite a complicated issue, and if they can do that, then do share.
Okay, thank you very much. And turning to the research itself, I mean, you set out very clearly the 3 work packages, and so the phases of the research, and it's very clear to see how your findings will be translated into practice, which is fantastic. But I wondered if, whilst you've been reflecting on your research findings, if there's any areas that you would you do anything differently if you were to sort of go back to the beginning and be recruiting participants, for instance? Would you do anything differently? Were there any sort of areas that you uncovered which you wish you'd had more capacity or time to unpick a bit further? And we do have a question from Remedy Max, which was, did your study also screen for comorbidity of other addictions, such as behavior addictions like eating disorders or problem gambling, which did, and also did people in your research report any other mental health issues? So was there anything else that sort of uncovered that maybe you'd want to look back at it in a different way?
I mean, should I take the sort of first bit of that, and then maybe you pick up on the rest, Kat? I think in terms of doing things differently, we already had to make a lot of changes because we started this in lockdown, and a lot of the ways that I think you would go around sort of contacting and engaging, particularly with community groups, when you turn up and you chat to people and you build relationships, we couldn't do, and that was really really tricky, and I think made things a bit slower in the early stages. We did have another part of this particular work package, which I had wanted to do a more provider focused piece of work where I'd look at relationships between different providers using kind of a survey and social network analysis to understand which providers were working with which providers and in which ways, and conducting an online survey of people working in substance use and mental health in the middle of pandemic was just that didn't go well. I think fortunately the data that came out of the interviews has been so rich and kind of useful that it's not been such a massive loss that we haven't been able to do very much with the survey. But maybe Kat can say something more about what she would have done differently.
I think one of the, I said it in the beginning when I was presenting the sample is probably around people from Black and ethnic minority communities probably aren't represented in the study as well as they could have been. I think that's something that we do need to address. I mean, in the Northeast and North Cumbria, we do have a small the population of those communities is smaller, but it's still important that we work with them and we think about what inequalities are increased for people in those populations. So that's work that we need to do. I think overall we did get a fairly good representative population. I think people were more likely to come forward if they'd been in touch with alcohol services and if they identified as a heavy drinker. It was harder to get people who perhaps weren't in touch with alcohol services. And we didn't have a lot of success recruiting through primary care, although we did get a few people through primary care. So it's those people who perhaps haven't been in touch as much with alcohol services. It would have been nice to have more people like that. But I think because people have been through the journey, you still kind of pick up some of that in their accounts. That's kind of that stage of the journey. So it's still there, but it's fewer people who are still at that stage, I guess. And the second part of the question was around other mental illness and other addictions within the populations. Nobody within the interviews spoke about gambling, but that it wasn't probed, but it didn't come up either. A lot of people did have experiences of other mental ill health. It was really common in the sample. In fact, it became apparent early on that it was going to be, and I had this conversation with a few of the people we were recruiting through, it's going to be really difficult to get people who are just drinking and depression because most people have got a lot of other complex needs and a lot of other things going on. So, we wanted to really embrace that sort of complexity within the sample. So, yeah, a lot of people did have other mental illness and other experiences. A lot of drug use, obviously, as well. So, yeah, that's in the sample.
Kind of physical ill health.
Ill health as well, absolutely. And that's. I mean, we're at the workshop stage now for the study, and that's really important in terms of how we're including people as well. So it's really important. And thinking about the intervention as well. So, yeah.
Okay, thank you. I was just thinking about I suppose the complexities of people's lives. I was thinking when you were talking about through some of your findings about people who had depression and effectively, I suppose my take on it was then chose to self-medicate with alcohol because of their depression led to their alcohol use. Did you sort of come across any sort of reasons behind that? Was it, as you mentioned, a bit of shame and stigma around having a severe mental health problem that led people to self-medicate rather than seek formal support, or was it barriers around seeking formal support that were the problem?
I mean, I think probably a combination of those, but also where we did the work in a very heavy drinking region, fairly heavy alcohol use is probably more socially normalized. And I think one of the stories that Kat told of somebody who was already drinking at quite heavy levels, but then when sort of, they're hit with kind of challenging life situations, you've already got that kind of pattern of behavior, and it's probably, you know, it's relatively easy to use that as a kind of as a way of self-medication. So I think it's probably all the kind of the service access issues that you mentioned, but also just the fact that it's you know, regionally, and I guess just societally, it's a common message, isn't it, that, you know, you have a glass of wine at the end of the day to wind down, and, you know, we associate it with self-care and self-love, a treat, a celebration. It's very difficult to step out of that wider context.
Yeah, okay, thank you. Well, so we've had a couple of other interesting questions come in. Hiran Thanki has asked a couple of questions. Hiran, would you like to speak? Would like to ask your questions yourself if you're on the call still? Are you there, Hiran? Okay, well, what Hiran did ask was what written materials are given to practitioners around heavy alcohol use and depression, and what's already out there that's been provided to practitioners that might actually be helpful. And did also ask how are you getting your findings across to commissioners more generally? I know you did touch on that in terms of what you want to influence, but how are you taking that forward with commissioners to try and influence what they do?
Taking the kind of the last part of the question, throughout this, we're working quite closely with various groups within the our local integrated care system. So in the North East and North Cumbria ICS, there is a lot of activity to try and progress this agenda. So we've got kind of an alcohol group. We've got kind of mental health evidence and evaluation group. We've also got an alcohol and mental health group, which represents kind of, you know, leading people in sort of policy and practice from across the region. And Kat and I are a part of all those groups, and we kind of meet regularly to share, you know, updates on what's happening with the research, and sort of key points we've presented and asked for some feedback and reflections from that group. I mean, tomorrow we've got our service provider workshop, and that is another opportunity for people who are more kind of based in practice and based on kind of that side, to give their thoughts on the research and on the resource that we're developing, although we are being beset somewhat by COVID in some of our attendance numbers. But yeah, we are making, you know, substantial efforts to, you know, to make sure that those kind of needs and that it's feasible and, you know, realistic, whatever it is that we're kind of recommending.
The other question was about written materials, wasn't it?
Yeah. I mean, sorry.
I was just going to say, because we've interviewed professionals as well as part of the study, which we haven't presented today, 26 professionals working across the region. And my sense is from those interviews that there's very little training around comorbid alcohol use and depression, and often they haven't got access to any advice about how to deal with it. I don't know, Amy, what's your sense?
I would agree. During this, we were also part of, it was an ICS-led project to kind of map the level of sort of training and understanding in different sort of sectors of the system, and looking at kind of secondary care in particular, where I guess you get a lot of the very dependent drinkers are kind of, you know, bouncing in and out of A&E, for example. They've found there's a real kind of lack of understanding, skills, expertise around what to do with heavy drinkers in those settings, and that is something that they're trying to take action on. But yeah, I mean, I think from both sides of the narratives, the message coming through is that people are often relatively poorly equipped, although it sounded, this obviously isn't fully generalizable. It was, it's a piece of qualitative work. It sounded as though both the alcohol services and more so the voluntary sector seemed to have more kind of rounded approach to dealing with individuals, as opposed to some of the kind of statutory mental health services.
Oh, well, that's really interesting. I think throws up lots of questions as to how services evolve over time and how they're commissioned, and just how important the commissioning process is in terms of making services work for the people who use them. And on that note, we do have, well, Jonathan, I don't know if Jonathan's still in the meeting, didn't ask a question, but made an observation about the importance of peer support. Jonathan, would you like to say anything about that?
Well, I was delighted that Amy brought that in because, as I said, there's a wealth accumulated over decades about managing mood and drinking by people who are in recovery. And I was also very pleased to see a note just arrived that occupational therapy could indeed have a lot to offer. The importance of medication in this area is grossly overvalued. Not only do antidepressants actually have a very low efficacy, specifically for alcohol problems, there are randomized controlled trials which show more drinking in those who've been randomly allocated in studies to the antidepressant than to those allocated to the placebo. Not widely known, and it's really embarrassing for British medicine, and we're not alone in this, at the extraordinary prevalence of antidepressant use, often with very little effect.
Okay, thank you. I think there's lots, that's probably an entirely separate debate about the use of antidepressants, but is there anything in particular around the importance of peer support and people in recovery supporting others in recovery that you uncovered in your research, Amy and Kat?
I think that we didn't really emphasize. I mentioned it a bit when I was talking about kind of the alcohol services and things, but it came through really strongly in our findings, the value of peer support. I think, it's the history of AA and sorry, go on.
I was gonna say it's come through almost even more strongly in the workshop, didn't it?
Yeah.
Because when we did the workshop, we were trying to get people to think about sort of technology in the absolute widest sense of the word, and we kind of said, in which situations might sort of which types of technology be appropriate, and where is it not at all the right way to go. And one of the things that we mentioned was things like video appointments with care providers, and they were really unpopular. People just didn't like them. They liked the option of kind of real-time chatting, messaging with a provider, but not face-to-face. What they did want was some help to be able to access peer support online, particularly people who are living in, kind of more rural locations that might find it quite difficult to get to groups regularly. They really liked the idea of kind of online peer support groups, and lots of people, even though they started the pandemic feeling quite kind of anxious and not really sure that online was the way to go for them, had found it actually quite useful and supportive, and got more used to and more comfortable with online kind of peer support as time had gone by. And I can't speak personally to the efficacy of kind of antidepressants, but all we can say is from some of the stories that we found, there's clearly people who have been medicated for depression for years and years, and nobody has really monitored either the mental health situation in a kind of robust way, and they definitely haven't asked them about their drinking.
That once again highlights the disconnect between looking at people as in terms of their mental health versus alcohol use. I was wondering if Andrew Cass is still on the call, who thought that your research was particularly helpful in terms of discussions that his organisation is having with your commissioner in the Wirral. Andrew, would you like to speak to that?
Yeah, it's really relevant. So there was a conversation that actually took place yesterday, and it's that kind of gap between IAP services and secondary care, which we're finding that there's I don't know, we currently prescribe to around about 1,600 people a year, and the percentage of people that have some kind of either self-diagnosed or GP prescribed medication is a significant portion of those people. And then connecting up with IAP services, it's then that challenge of we can't work with you because it doesn't fit in within the policy guidelines relating to substance misuse. And then it comes back to us. And it's almost like a double whammy, because potentially you're trying to deal with the addiction, which the person potentially may well be using substances to cope with their addiction. You reduce their addiction, but then clarity of thought, emotional well-being increases, and the person then potentially their emotional well-being actually goes worse as a result of getting that enhanced clarity from not using substances to mask the trauma. So you're almost in a double whammy, and you can see the person kind of going round and round the system. So yeah, we're in having conversations at the moment with commissioners and IAP providers and secondary care providers about how we can change the system really to support and enable people to receive better treatment.
Yeah, because with all the round and round, I mean, what some of the stories are about, the kind of the waiting between those services and the backwards and forwards, and I think often the misinterpretation and misapplication of guidelines, because actually none of the guidelines say that you should be turned away because of either, you know, if you look at any of them, they say explicitly it should not be used as a reason to deny support, and yet, you know, almost every single person we spoke to said it had been used in that way. I don't know.
That is true.
I was just going to say that we interviewed, again, this presentation isn't about the blended professionals that we interviewed, but we did interview some people who work for IAPT. I don't know if there's anybody from IAPT on this call, but they felt that they don't get any training at all about alcohol. You know, in the years, I think is it a year-long training you have to be working as an IAPT kind of practitioner, and alcohol isn't even mentioned.
I definitely think there's more that we can do. We are looking at that joint training from both sides really, and looking at how we can work alongside each other within premises, so that, you know, the better relationship between workers, hopefully that could then impact on the treatment that the patient receives. So there is work that I think we can do to improve understanding.
I think providers as well, and this becomes particularly apparent when we're talking about digitally based care, are really worried about risk. So part of the reason of kind of pushing people out and saying, you know, this person's just too complicated, is feeling that they're personally inadequately trained to deal with that level of complexity, and don't want to, you know, worry about the kind of the risk attached to that individual. So it's easier to kind of push them out and pass them on to someone else. And that becomes apparent when it's, you know, face to face or in a kind of digital space.
So Angela, and I don't think Angela is still on the call. If she is, and if you are, Angela, please do speak up. But Angela highlighted guidance about drug and alcohol use should not be used as an automatic exclusion criterion, as you were just saying, for accessing IAPT support. But I don't know if you think, is it purely a resource/training issue that is the barrier, do you think, or is there anything more to it?
I think it's got lots of different things. I think it's partly training. I think it is being kind of quite risk averse, because people are worried about what will happen if they take on this individual who, you know, could be quite difficult to deal with, and if they don't feel kind of adequately sort of, you know, they've got enough expertise, then I think sometimes it's as much to do with that. I think it's, you know, just generally lack of resource and capacity. You know, they don't have the time that it takes to work with people in a real kind of individual, tailored, sympathetic way. So, you know, in those circumstances, people are kind of either bounced out of services, or the kind of the least worst option for people is often to try and get to, you know, the sort of voluntary and community sector, which can provide fantastic holistic support, but are themselves horribly under-resourced and under kind of constant pressure of having to, you know, kind of rebid for funding so they can keep going for another year. And you know, they're not necessarily the people to be always having to pick up the pieces for this, you know, group of very vulnerable service users.
Yeah. Okay. Thank you. So unrelated, and I think Jonathan mentioned it earlier, but is John still on the call? John was talking about the role of occupational therapists in this field.
Hello, I'm still here. Yes, sorry. I do apologise. I did miss the beginning. But yeah, just kind of chipping in that occupational therapy perspective, because the thing that sort of resonated with me was, you know, I've worked in substance misuse services and seen it from kind of that side. Oh, it's mental health, you know, or it's drug use. You know, you need to deal with that. And I've also worked in a mental health service and seen it from that side as well. So you've got, you know, it's still so common to have people caught up in the middle. I'm in a really fortunate position, sort of having kind of recently started in a brand new post, where I do have the time to kind of really understand how someone's substance misuse and their co-occurring mental health issues are kind of interlinked, and kind of the, you know, the skills and approaches that are needed, not just by myself, but by all the services involved. And it just kind of really a bit of shameless promotion there, really, you know, to kind of get the role on people's radars. But yeah, kind of it is that, well, we aim for that really truly holistic approach, you know, kind of really taking the time. So, okay, someone might not come to a clinic appointment because they don't like the clinic, or kind of getting there may be difficult. You know, they might have the skills to kind of organise and initiate or budget, you know, and so suddenly it becomes this massive issue of kind of engagement, which is sometimes relegated to, oh, well, they're not motivated, they didn't come. Well, yeah. Why aren't they motivated? What is motivation? I'm kind of making friends in my team by asking that question, you know, well, what do you mean they're not motivated? Because there's so much more to it. There's the practical elements, and there's the sort of, you know, physical elements of it as well. So yeah, kind of just kind of bringing that perspective really to kind of everything. And I do hope it will kind of grow throughout the UK as well, with different services. So yeah, thank you for bringing me in there.
Not at all. It's exciting to hear about a new approach, to be honest, that I've not come across as well. And it sounds like a really worthwhile, and sort of, as this it is occupational therapy, isn't it, to take that holistic approach. So it sounds great. Thank you very much.
Yeah,
if you've got any reflections on that, Amy.
I don't know if we interviewed anyone from OT. I'm not sure that we did, but I wonder, we've got a kind of a final workshop, haven't we, in July. I wonder if it's worth trying to find an OT that could come along, because
so are you doing them in person? There, you know, there's quite a few OTs in substance misuse services throughout Scotland. So I'm very happy to facilitate that connection.
Yes, please. Yes, I mean, it may, the workshops are in person, because we're doing lots of, you know, kind of post-it flip chart type work where we can, but it might be possible, you know, to have a sort of a conversation outside those workshops and just hear a bit more about what's happening in OT, because it certainly sounds, you know, much more on the lines of the kind of support that we think is needed.
Sure. If I'm afraid I'm going to have to leave in just a moment. I have some breaking free online training, but if I pop my work email, if you kind of take that down, I'm very happy to kind of have a conversation there.
Yeah, just send that in to us, John, and we'll sort it out. We'll connect you.
Thank you so much for your time today, and kind of the comics. I think that's such a really powerful way of communicating that as well. Really, really good. So thank you very much for today.
Okay, thank you. I see a few comments here that there are that there are occupational therapists working in a few substance use services across the country. So thank you very much. Now I'll just turn to our final question. So this will be from Professor Carol Emsley, who is a co-chair of SARN. So I'm delighted, Carol, if you would just like to ask your question about socioeconomic status and stigma.
Thanks, Eleanor, and thanks to the speakers. Yeah, I was just wondering about whether there was any variation by gender across the sample or socioeconomic status, and we've been talking about stigma, and it'd be interesting to reflect on whether male or female respondents, as far as you could tell, felt any more stigma around seeking help for these conditions. I realise we've got 2 minutes to wrap up, so any brief reflections would be fantastic. Thank you.
Yes, yes, we did talk, Amy and I were talking about what to present, and I said we haven't presented around gender, but yeah, it is coming through really strongly in the findings. In terms of women wanting to disclose alcohol use, it definitely came through that perhaps they, there's a lot of research, isn't there, that women seek help for alcohol later, and that I think that comes through really strongly in the findings. And then some of the men's concerns about, around talking about mental health as well, that came through quite a bit as well. I think there's issues around kind of the support that women get if they've got children compared to women who don't get children as well. I was trying to present that in the Christina case study. No, I can't remember which case study it was.
Yeah.
The Christina case study where she thought she was getting support because of her children. And I think, yeah, certainly there were women who seemed to be having more joined up care if they had children, but the women who didn't have children perhaps weren't getting that. So there's that kind of differences within the genders as well. In terms of socioeconomic status, I think most of our participants were in lower socioeconomic groups anyway, so there was relatively little difference, but it was possible to see those who had sort of the financial resources to access sort of private support. You could see that perhaps some of the gaps were being plugged. But again, people talked about sort of accessing private rehab and things, and actually you've gone to private rehab and then you come out of private rehab and you've got nothing. Again, that can still be challenging. So yeah, there are definitely differences coming through, but we need to look at those a little bit more. But yeah, thank you for the question. I don't know, Amy, did you have anything to say about that?
No, just yeah, I mean, I think we thought about that real focus on women as carers, and it's just usually done because it's a safeguarding issue. It's not necessarily out of concern for the woman. But the men, particularly because a lot of them, they're single, middle-aged, living alone, very few social kind of sources of support. I think that kind of narrative is quite clear amongst the male sample, and in the workshops again, that sort of reluctance to show vulnerability and seek help for mental ill health was also a strong message in terms of kind of how we framed and positioned the resource, that we need to kind of consider some of those gendered factors. Well,
thank you.
Well, that's all we've got time for, I'm afraid. And now I feel like the discussion's about to really go off in lots of interesting directions. So I'm really sorry to have to bring it to a close now, but it was brilliant to hear about your research. It was really insightful, and also just, well, as I said, this is my passion, is the fact that you're wanting to use your research to influence policy and practice is fantastic. And that came out really loud and clear, and obviously has resonated with everyone in the meeting today who's wanting to take your presentation and run with it. So thank you very, very much. And thank you to everyone for asking such a wide range of questions and making some really interesting and useful points today as well. So we will follow up today. We'll be sending out the recording to everyone who's registered for today's event, as well as putting it on our website, sharing it on Twitter, and we'll also be sending out a report just giving an overview of today's discussion as well. Please do sign up to the SHAAP and SARN mailing lists, and you'll always then hear about events like this. But all I can really say is this is our final occasional of 2022. So I hope that you found today's and all of the occasionals interesting and thought-provoking, and have given you something to take away and to either think about or even do something with as well. So thank you very much for coming. We will be sharing the theme for next year's occasionals, probably towards the end of this year. So do keep a lookout for that. And if you've got any thoughts or suggestions about future occasionals, please do drop us a line. We'd love to hear from you. So on behalf of SHAAP and SARN, and the co-chairs of SARN, and Professor Carol Emsley and Professor Aisha Holloway, I'd like to thank everybody for participating so positively in these occasionals, and to all our excellent and thought-provoking presenters, especially today. So thank you so much, and hope to see you again soon.
Thank you.